Good, how are you?
Good. Welcome to week 9. You're almost done. Almost done. Only have a couple more weeks, and then you have your nice little Christmas break as well. So that's always a plus, right? So just some housekeeping. Remember to stay on camera. If you're not on camera and I call your name and you don't reply or I send you a message, I'll put you back in the waiting room. Um, But we'll just, so week 9, you have your domestic violence and cultural competency case study. Your HESI prep assignment is also due. And then you'll have your week 9 Saunders questions that are due. Next week, we will have exam 3, which is your final exam prior to HESI. Your vulnerable populations project is due on that Sunday, which is the 14th. Um, Sunday, also the 14th, is when we will have our live review for HESI. So if you're able to attend that. And then in week 11, you have your HESI, and your last set of Saunders questions is due that week as well. And then your HESI remediation is due December 22nd. And then remember for week 12, right, we have that alternate day that we are going to meet. And I'm going to pull it up in Canvas. Hopefully, I don't know, anybody else having issues with Canvas today? Like going like really, really, really slow.
Not
Okay.
loading.
No, like it took me forever to get
It
Canvas.
crashed.
Yeah, it just keeps spinning. And then I got a message saying that it was under, I don't know what, I don't remember what the message said, to tell you the truth. Um, my calendar is coming. There we go. All right. So Sunday night at 7 is your exam 3 live review. Then on the 14th at 7 is your HESI review. And then we will meet on Tuesday, the 23rd at 1 for that alternate day class meeting for your week 12 attendance. So don't forget about that. I will post another, I posted it in the announcements for this week, but I will post it again next week. Just keep it in the back of your head. So that you get attendance because you don't want to go 14 days without attendance. Your HESI will count as attendance for your week 11. So as long as you take your HESI, you'll get attendance for week 11. Any questions on any of the remaining assignments that are due for the rest of the term? Just keep up, keep doing what y'all are doing. Aquia, are you there? There you are. Okay. Just keep doing what you're doing. You guys gonna get through the rest of this term. Um, so for week 9, the topics are um human violence and abuse, and then cultural influences in nursing. So your readings came out of your med surge text, which was chapter 45, I believe, um, and then chapters 3 and 14 in your fundamentals book. So we will go ahead and get started if anybody have any other questions. So we'll start with violence. Um, there's lots of different violence out there. So, what are some types of violence that we may come across as nurses, whether it's in community, or within healthcare itself?
Domestic.
Domestic violence, that's a big one. Um, and so when we look at violence, Um, what is violence? Tell me what violence is.
It can be physical, emotional, causing
mental,
harm or injury to someone else.
causing injury. Yeah,
Intentionally.
intentional. Yeah. So Nishay, LaShawn, Sarah, correct, right? It's emotional, it's physical, um, it causes harm, and it is usually absolutely intentional. Um, and so what why do you think violence happens? I know it could
Some
be a
people are
question for
just
you.
sick, I say.
Prior
Okay.
exposure.
Prior exposure, right? It could be, LaShawn, I'll just twist that around, could be a result of mental illness, right?
Unable to cope with their
Something.
like strong emotions, so they take it out in other ways.
Sometimes it could be
So
stress, poor coping
stress,
skills.
poor,
Mm-hmm.
very good, poor coping skills. It is a maladaptive coping mechanism, right? So all of your answers are absolutely correct, right? We have all these emotions, and don't always know how to express them positively or to cope with negative feelings. And so
And
violence.
trauma could be violence as well.
Say that again.
Trauma.
Trauma. Yeah. So absolutely. So violence is, like I said, it's a maladaptive coping mechanism. And it is very popular in, or not popular, the wrong word. It's a common in vulnerable populations, just like substance abuse is. And it's a way of exhibiting or regaining control. Um, and a lot of times violence is predictable. It could be, if it's predictable, then sometimes it's even preventable. If we look at both the perpetrators of violence as well as the victims of violence. And so, like some of you had mentioned, previous exposure to violence can actually increase their chances, or their their, what's the word I'm looking for, the possibility of them becoming violent, right? So think of kids that grow up in abusive households, or they're witnesses to abuse within the home, right? They are more likely to portray that as, even as kids, but then again, as they grow and they get older. And abusers were often, beaten when they were children, or like I said, they may have witnessed one of their siblings being abused. And so they have learned throughout their childhood that violence is a way for them to manage conflict, right? And so that's why we consider it a maladaptive coping mechanism. High levels of violence also contribute to health disparities, adverse health outcomes. So, when we look at being a maladaptive coping mechanism, stress, right, is often um, stress is often the start of it, right? And so chronic stress, what are some of the potential health risks leading to, as a result of chronic stress? What are some of the physiological results of chronic stress? What can it cause in our bodies?
Weight loss.
Okay, weight loss,
High blood pressure.
high blood pressure,
Anxiety.
Inflammation.
Weight gain.
anxiety. Say that again, Julianne.
Weight gain.
Weight gain. Um, Yeah, so weight gain or weight loss, right? We can go either way with that, right? Some people, what happens when they're stressed? They don't eat, right? So they may lose weight. What about other people? Other people, when they're stressed, what do? They eat, right?
Eat a lot.
Eat a lot, right? So it can go either way. Um, Diabetes is a potential result of chronic stress as well. Certain cancers It could result in hormonal dysfunctions, and then the, associated symptoms, which whatever hormone is being dysfunctional, right? So, high stress could also lead to reproductive issues, right? It could, result in not, temporary infertility, right? Not being able to get pregnant. For men, it can lead to impotence. Okay, so chronic stress can have just lay torture on your body. So with that being said, when we look at, we talked about some of the different types of, violence. Remember, as a nurse, we are mandatory reporters, correct? And so, especially if it's violence against children, or the elderly or any other vulnerable adult, right? Because, if we have somebody that has cognitive impairments, right, even though they're an adult, right, that would be considered a vulnerable population. So think about that. We are mandatory reporters. So we don't, and then with adults, it's a little bit different. So if I have an adult who is alert, oriented, completely of sound mind, we don't report that violence. All right. We have to have their permission. So there's a big difference there, right? We report if it's a vulnerable population, like the children or the elderly, but we don't with adults. Why do you think we don't report violence without adults' permission?
They may not be ready to leave,
Okay.
or they could be fearful that something bad or worse may happen.
Correct, right? They may be fearful to leave. They may be fearful that something worse is going to happen. They may not have that escape plan, right, to get out of the situation. And without that, right, they're kind of, stuck. Um, And, if we, notify the police, without their permission or without them being aware, then that could definitely lead to, possibly an escalation in that violence. So we want to make sure that they have everything, prepared for them in order to make that escape. So what do we do? What can we do? What can we do in that situation? You have, an adult that you can, maybe have recognize the signs of abuse, or, even maybe just suspect the abuse. How can we relate? How do we approach that subject with that person?
You can ask him about it, and then if you feel it's appropriate, offer him resources and try to get him connected to like social work.
Right. So we can ask them about that. One of the big things that we want to do, and this would go for even if we were interviewing an elderly person about suspected abuse, is you want them to be alone, right? You don't want family members or, other people in the room when you ask about the abuse, right? You want it to be a one-on-one situation, especially with the elderly. Think about that. You have an elderly man or an elderly woman that comes in, and you see, signs of abuse, maybe, bruising that's in various stages of healings or potentially other signs, and they're there with a family member. Are they going to answer you honestly in front of a family member if they're the potential abuser? Right? They're probably not going to answer you, for many different reasons. One, out of fear, right? They, if they do talk about the abuse in front of the abuser, then that might increase the risk for even worse abuse, right? Or they may not want to tell you as well because they may not want to be removed from their home, right? They, they may, be fearful that they may end up in hospital for a long period of time or in a long-term care or other type of situation where they are not, in their homes. So there's a variety of reasons why somebody may not be honest about the type, about being abused. And so, it's just trying to be aware of what is going on. When we look at human abuse, abuse is about power and control. And that is, it's, how they can control someone. And then when we look at family violence, it's usually between the most powerful and the least powerful, right? And, who is the most powerful in the house and who is the least powerful. And that could be a child or it could be a significant other. And a lot of times family violence as well is perpetrated in a cycle again, like we said earlier. If a child grows up seeing violence used as a method of control, whether it's over themselves as children or even their mother or their caregiver, they are more likely to continue that cycle as they become adults. What types of, so vulnerable populations, we talked about that. What are some risk factors do you think, other than the exposure to violence growing up? And, what are some other potential risk factors that can cause violence to occur?
Socioeconomic.
The socioeconomic status, right? What if they're in an economic strain, they may not, have the resources to care for their families, keep a roof over their head, buy food, that kind of thing. Substance abuse is a huge factor in abuse as well. That was a good one. Good job, Destiny. Family crisis or dealing with a crisis is another potential risk factor, whether it's, unemployment, marital strain, unplanned pregnancies, even infidelity could lead to an increase in violence or cause a violent situation to occur. Social isolation is another one. Especially when you look at, if maybe, one of the members of the family is isolated from their friends, from their family members, or doesn't have a connection, that also increases the risk for violence. It also decreases the social support, right? So when they're going through that crisis, they may not have anybody to lean on, to go to talk about the stress or find ways to cope with the stress. So there's, lots of, different factors that can come into it. When we look at intimate partner violence and violence from pregnancy, often will actually increase violence. And that could be the result of the stress of having another mouth to feed, or it could be just the stress of the pregnancy. And, anybody that's been pregnant knows that, women go through some changes, right, when they're pregnant. And so, that could be a contributing factor as well. So working with this population, they're going to show signs and symptoms. So what do you think some of the symptoms that victims of violence will exhibit? Whether it's an adult or a child. We'll start with children. What do you think some symptoms that other than the things, I'm saying symptoms, I'm not saying signs, right? We can see bruising and things like that. But what are some symptoms that kids may experience as a victim of abuse?
Maybe withdrawing from people.
Anxiety,
Mm.
depression,
Anxiety, withdrawn behavior. What else?
depression.
Bruising in different stages.
The
They're
kids are
gonna
gonna be angry too.
they may be very angry. Very good.
Oh yeah,
Um,
they could be bullies. Like they could see the behaviors and then exhibit the same behaviors.
okay, they can be the bullies. You're absolutely correct. They can be the bullies. Um, they also may have some more of those psychosomatic complaints. What are psychosomatic complaints? Have you heard that before? Psychosomatic complaints are things that are more psychologically based, okay, rather than disease based. So, frequent headaches, stomach aches,
Yeah, like they could say like their stomach hurts, but really they're just really like sad and like or they had like a rough night.
right? Or they're very stressed, right? Anybody and anybody who's ever been really stressed knows, right? That stress we talked about, right? Some of the chronic diseases that can be the result of stress. But think about how you feel when you're stressed, right? Headaches, upset stomach, bedwetting could also be another symptom that kids may experience as a result. Um, and then, like you guys said, anxiety, depression, withdrawn behavior. Um, they also may, depending on the type of abuse that they're experiencing, right? They also may have some inappropriate sexual behaviors or knowledge that they shouldn't have at their age. Delayed puberty or precocious puberty. It also could lead to menstrual disorders. What about adults? What about abused women? What are some complaints or symptoms that they may experience? And it's a hard topic. I know it is. But same thing. They may experience chronic headaches. They
Early
also
menopause. I'm sorry.
early, that's okay. They may have palpitations, they may have sleep disturbances, appetite disturbances, sexual dysfunction, irritable bowel, urinary frequency and urgency, recurrent vaginal infections. Um, Abused women also experience more miscarriages, preterm birth, low birth weight infants. And like I said earlier, a lot of times too, the abuse actually may escalate during pregnancy. And so when we look at, and it's hard and, everybody, unfortunately, these are, situations in nursing that we may come across, and have to deal with it. So when we do suspect that there is any kind of abuse in adult, again, we're going to ask, biggest thing, right, is making sure that we have that therapeutic relationship established, that we're using really good communication. We're not being judged, we don't want to be judgmental, right? We want to be completely non-judgmental when we're talking with somebody about them potentially being in an abusive relationship. You want them to be able to report report it. You don't want them to feel shame or be embarrassed about the situation. And especially remember too, and we focus a lot on women and kids and the elderly, but men can be the victims of abuse as well, right? We don't often think about that. And so they can be the victim of abuse. And what do you think with men? Do you think they'll be more open or less open than a woman about being abused?
Less.
Less.
Right, right. Because they're probably
They'll be embarrassed.
more likely to be embarrassed. Absolutely. Right. So that is where we kind of have to be, again, really non-judgmental about that. And so again, if they don't have any, so if they don't have social support, if they have lots of stress, multiple stress factors, and a history of abuse, right, then they're going to also be more likely to abuse. So we want to try to stop this cycle. When we look at the elderly, and so the elderly, they're also at risk. And so the elderly, it could be emotional, it could be physical, it could be financial. And so, we have to look at that, whether it's abuse, whether it's neglect. What are some ways, what is emotional abuse? What would how do you think, what are some emotional abuse techniques that people would use towards the elderly? I know.
Taking
Threatening their
away their
family.
items.
Emotional abuse.
Degrading them.
Degrading them, demeaning them, putting them down, right? Calling them names, scaring them, right? Embarrassing them. It could also be isolating them, right, from other members of the family or from their friends. And it could be destroying their property as well. What about neglect? What is neglect?
Like if they're incontinence, not changing them in the amount and the hours and stuff.
Okay, not changing them if they're incontinent, right? Letting them
Not
sit
let not letting them have visitors and things like that, not letting them do things on their own.
okay,
Sometimes they're able to do things on their own, and they want to keep them in rooms by themselves and isolate them from family members so they don't know what's going on.
okay, absolutely. What else? Neglect,
Not
not,
feeding them if they can't feed themselves.
not feeding them, not giving them clothes to wear,
Not
not
giving them oral care or washing them up.
not letting them clean themselves, not taking them to the doctor when they need to be taken to the doctor. Um, and so, that what are some factors do you think that leads to abuse or neglect of the elderly person?
Lack of support to take care of the elderly person.
Okay, lack of support, that's a huge one, right? What else? So lack of support, substance abuse could be another potential, right? That kind of brings us into financial abuse. So what is financial abuse?
Taking
Stealing.
their money, taking their checks.
Taking their money, taking their checks.
Or like
Um,
withdrawing it for them, only letting them, like not letting them use their money.
yeah. Okay.
Taking
Yeah.
their money when you know you're not supposed to, even if they gave it to you willingly.
I was about to say, taking advantage of them. Sometimes people give you a sob story and they could be lying, saying that they need X amount of money for this, and they're basically using them.
Yep. Um, so this could be um, because of substance abuse, right? Or it's usually a child, right, that is they're, performing the abuse. Um, whether it's substance abuse or they don't want to get a job, right? And they're using their adult, their elderly parents as, their support system. Um, and kind of leaving that person with nothing. And, and just because the person is there, they, doesn't mean that they have the rights, right, to take all of the stuff from that person. So just like with recognizing the signs and symptoms of your abuse in your younger and adults, right? Looking at the elderly population and being able to recognize those. And a lot of it, like I said, they may be just as reluctant to report abuse for for a variety of reasons. It could be because they don't, they like don't want to leave their house, or they don't want to get their loved one in trouble, or they're they're scared that the abuse can get worse if they do tell. So there's lots of different reasons why that can occur. And this next part of this is also a touchy subject. And we still have to touch on it, is suicide. Suicide is self-directed violence, right? It is also the second leading cause of death in young adults, ages 10 to 34. What are some of the leading risk factors for suicide?
Depression,
Feeling hopeless.
Depression. Say that again.
PTSD,
PTSD, depression,
Substance abuse.
substance abuse. Denasia, I didn't hear you, hon.
Feeling hopeless. Feeling like
Yeah.
that's the only answer. Mental health.
Feeling hopeless, right? What else? What about in
Bu-
our kids?
bullying.
Bullying. Bullying is a big one. You read about it in the news, right? And see the posts. Um, and now this, and you know what? I'm old, guys, okay? My kids are older too, but a lot of the cyberbullying, right? And some of the online stuff that goes on is it's insane. Which has led, to I was reading an article, and I don't remember the whole situation. I wish I could, but it was a younger kid, and I want to say, um, he or she, I can't remember if it was a he or she, had somehow gotten wrapped up into like an online situation with, I think, like I don't, like an older person playing like a younger person type thing, and had sent this person some explicit pictures, so to speak. And the person then was blackmailing him or her for money. Otherwise, they said that they were going to release the photos and, let their family and friends and everybody see the photos. So basically was trying to blackmail this young kid. And then the child or the kid, I can't remember, he was under 18. I just remember that. And the child ended up committing suicide as a result. And then all of that information kind of came out after the fact, right? And other risk factors that are, when we look at suicide, if they've had a prior suicide attempt, if they have a family history of suicide, so if other members of their family have committed suicide, that does increase the risk for suicide to occur. Substance abuse, we talked about mental health disorders, we talked about It is very high in the LGBTQ community, absolutely, Dominique. What else? Firearms in the home, incarceration is another risk factor for suicide, and exposure to the suicidal behavior of others, whether it's family, whether it's peers, whether it's people in the media. Um, and so, you know, sexual assault, very good. Yep, lots of different reasons why suicide can occur. And sometimes, recognizing the signs of suicide is, can be difficult, although there are signs. And if you look at some of the, people that have posted, or written articles and things after, family members or friends have committed suicide. Hindsight is 2020, right? They go back and they're like, oh, we now, we can understand why they were doing this or, why they were doing this. So, that could also be, another thing that we need to, really keep an eye out for. So with all of that, with violence, let's talk about the prevention. So primary, secondary, tertiary prevention regarding violence. So primary is prevention, right? So what are some primary prevention measures that we can implement to help to prevent or even reduce violence?
I think one big thing is like kind of like reducing the stigma around like mental health. Like, when somebody says they're depressed, people are just like, oh, like be happy, be positive. So I think one thing, even I don't know, like I feel like that takes like time to actually do, but like reducing the stigma and like, because a lot of people when they're like sad and depressed, like they won't get help, but like
Mhm.
making those resources like available, like having like pamphlets out about like, oh, are you like, there's depression pamphlets,
Mhm.
especially for like teenagers. Um, yeah,
I think
that's
any
really
Absolutely, to
stigma of
make it,
taking
yeah.
meds too. Taking meds, a lot of the time people say, "Oh, you don't need medicine. You don't need medicine."
hmm
Sometimes you do need meds to help you.
Mm-hmm. Mm-hmm.
At my
Absolutely,
kid's
both of
doctor's
those.
office, they always ask, is there a gun in the house? And they, if you have one, do you want a free gun lock? I think that would be like a primary.
That is a really good point. I remember this was a long time ago, but when I worked in peds, the doctor that I worked with, he was actually part of that initial study where we did that. So anybody that came in and they disclosed that there was a gun in the home, we offered them free gun locks. And it was a way, we didn't ask, was there any violence in the home? We didn't ask about abuse. We literally just asked if they had a gun in the home. And if they said yes, we offered them free gun locks, right? It's just something that we can do as a preventative measure. Um, and it's, when we look at violence, yes. Having guns in the homes, can, increase the risk for violence depending on the situation. Um, but we also have to look at it from a safety issue too, right? If there's guns in the homes, then kids can accidentally get a hold of those guns and potentially hurt themselves or others, right? Um, we actually had a patient, we had a 5-year-old who um they were living in a trailer on, actually not even like a trailer, like what is it, like a motorhome. So they were living on a motorhome on the boyfriend's parents' property. And so mom was at work, the boyfriend had the kids, the two girls, and he had laid them down for a nap in the motorhome and had gone into the house. In the process, dad was into, or the boyfriend was not into, he was into some bad stuff. He was into gangs and drugs and stuff. Um, the 5-year-old had seen him put the gun underneath the mattress. And so when he went into the house, um, she got up and she grabbed the gun and she ended up shooting herself in the head, and she survived. Um, Fortunately, when she did shoot herself, it literally, lots of blood. Um, it literally like just cracked her skull. Like the way she was holding the gun, and of course, imagine a 5-year-old shooting a handgun. It literally just fractured her skull. So she did have to have like an implant put in, and have it cleaned out, but she survived. So, those gun locks are an amazing thing. So that is a very good primary prevention. Um, what else? What else can we do? What other primary prevention measures can we use to prevent or uh, decrease violence?
Relaxation techniques.
Okay, relaxation techniques. Or what about schools teaching coping mechanisms, right? What about, so a lot of times growing up, right, we learn our coping mechanisms from our parents. But if our parents and our family have maladaptive coping mechanisms, right, then that's what the child is going to learn. So how about teaching good coping mechanisms, right, when they go to school? Anger management. What about some anger management programs? Those would also be, a good primary prevention measure. Trying to think of what else. When we look at um, moms or parents, um, teaching them about, just normal growth and development, right, can also help to prevent violence. Um, if they don't understand normal growth and development, right, they may have, um, what is the word, unrealistic expectations of what the child should be doing at any given age, right? Who has kids? Raise your hand if you have kids. Have you survived the 2-year-olds yet? Are we there yet? And
I
the
have a
3-year-old?
2-year-old right
I'm
now.
going through it right now.
Mine.
I'm
I
done.
had terrible threes.
I'm done.
Yep. So like the terrible twos, right? And then we get into the threes, and then we get the why questions. Why, but why, but why, but why, right? That's enough to drive anybody crazy, right? When that's the only word that you hear all day is why. And I used to like, I'd be like, I'd have to count to 10 and be like, I don't even know why. Like, I don't know how to answer this question. And when I was growing up back in my generation, because I am a Gen X, okay, um, it was always because I said so, right? If I asked my mom why or asked another adult, it's because I said so. So I wanted to try to break that cycle with my kids. And so when they ask why questions, I would try to answer. But there were some questions that I was like, I don't know. And then I would get, well, why didn't you know? And I'm like, okay, look, I don't know why I don't know.
The other day, my daughter was asking me something. I don't even know what question she asked me, and I forgot the response I gave her. But she said to me, "Mom, I'm trying to learn about life. I just want to learn about life." And she was right though, but still, she asks a million questions a day.
Yes, yes. So yes, but yeah, so I mean, and we know, I mean, anybody, even those of, some of you, we've all been kids too, and I'm sure we drove our parents crazy with those same questions. But understanding, right, the normal growth and development sometimes will kind of help you realize, okay, this is, this is a normal expected part of life here, and how are we going to handle that situation? Um, and then, you know, um, again, teaching parents good coping skills. We could also try home visits, right, for families that have or at high risk for violence. So like those are like, your parents that have some low social support, stress factors, a history of abuse, right? So we want to maybe try some home visits to work with that population, right, to kind of help get them, back on track. But lots of education, right? How to, and it even could be removing or reducing factors that contribute to stress, right? So what are, looking at what are some of the stresses um, that are happening in their lives, uh, you know, um, how can we help to reduce their stress, right? So it could be even like maybe referring them to some other services within the community, like, I don't know, social services. Maybe they need, even like, TANF and things like that. Um, but, just kind of looking around to see what it is that we can potentially help with. And so that brings us into, we'll leave abuse now for a while, and we'll talk about some cultural influences in nursing, or just cultural influences. So what's culture? Tell me about culture. We'll try to go through, from, into something a little bit more positive. So what is culture?
To me, I think culture is like a lifestyle almost.
It is your lifestyle, absolutely. So
It's
it's
like,
everything.
oh, sorry. I was gonna
No,
say
go
like
ahead.
the beliefs, like certain like what's the word? Like customs
Our
among
values too.
certain people.
Hmm. Absolutely. So culture is everything you believe to be true about the world, right? It's the beliefs, it's the values, it's the assumptions of life, or about life, that we pick up through socialization in in childhood, right? So, sure, everybody here, has maybe a different culture or similar cultures, right? But it's kind of how we grew up, right? So I'll just use myself as an example. I grew up in two completely different families. So my dad's side of the family, they were very strong Polish Catholics. Um, my great grandparents came over straight from Warsaw, Poland, um, and they had a very strong Catholic background, very not rigid religious, but very religious. And then on my mother's side of the family, my grandmother was born here in the United States. My grandfather, he was born in Germany and escaped Germany right after World War, or right before World War One. Um, they escaped Germany, they went to England, and there were seven of them. And so they came over, I want to say the oldest brother and my great grandmother came over first, and then they slowly got money to bring the rest of them over. And they were more kind of happy-go-lucky type family, right? Not very rigid. So it's two very different cultures, right? Um, and so we all have that, that cultural influence that has occurred in our lives as we have grown up. Different ethnic groups may have cultural similarities, right? But everybody is unique, right? Because we all grow up differently. Um, and so culture, it includes our language, our, the use of touch, the personal space, our body language. Culture also affects our perceptions of health and illness. It can influence our family structures, how we raise our kids, our time orientation, eye contact, all of those things. Just kind of really depends. Um, so what is the best way to find out about somebody's culture?
Ask them.
Ask them. Absolutely. Um, everybody is unique, okay? And just like I said, different ethnic groups, they may have cultural similarities, but even within a specific culture, a person may not, um, what's the word I'm looking for? They may not observe all of the aspects of that culture, right? And so to kind of clump everybody into one as like all Polish people are, do this, or all German people do this, right? Um, everybody is unique. So yes, I grew up in a very strong Polish Catholic family, grew up Catholic, went to Catholic school my whole life until I graduated from high school. Um, and kind of strayed away from religion after high school. Doesn't mean that I don't believe in God, right? But I just don't have, I didn't follow those didn't move forward with that very strong Polish background. Um, So everybody is a little bit different. So we approach everybody as unique. And we can learn about somebody's culture through observation, assessment, and asking them, right? What parts of your culture are important to your healthcare? How can we help to incorporate, you know, your cultural beliefs into your healthcare? Um, and, so we kind of want to, look at that as we, are taking care of members of other cultures. And so before we keep going, let's go ahead and take a break. Let's be back at 105. I'm sorry, 205. Mhm. All right. So what are some cultural practices that you know about that may affect someone's healthcare beliefs or their desire to receive treatment?
Blood
Jehovah's
transfusions.
Witness, they don't take blood.
Okay, I heard blood transfusion. Nishay, what did you say?
That's what
That's
Nashay
what I
said.
said.
Oh, okay. So blood transfusion's a good one. And so which culture does not accept blood transfusions?
Jehovah Witness.
Jehovah Witnesses, absolutely. Um,
Also, the person who's treating you depends on your cultural, because sometimes they only want like in Islamic cultures, only men are allowed to treat men and women are allowed to treat women.
that's a good point, right? That is a very good point. I want to say that's very big in the Muslim population as well, right? Especially Muslim men may not want women, right? Female nurses or even like female CNAs. That's a good one. Um, and it could, I mean, it could be it could be the desire to accept treatment or the willingness to accept treatments. It also could be um, diet, right? The foods that they eat, and how they kind of fit in with their cultural beliefs, right? Like your Jewish population and their kosher foods, right? How does that, how do we meet those needs of, that person in the hospital?
Isn't it
Um,
something like they were doing like pig implants or something, and people refused like pig implants or something like that because it was
mhm,
against their beliefs?
I
mhm.
think it was the skin transplants, niggas pig skin.
Yep. Yep. Because, because it's pork,
Or
And I
valves. Maybe
learned
it was a valve or something like that.
hmm
and I learned this term too about people with Hindu beliefs don't really like what is it? Like cow meat, beef. And I have a friend who grew up Hindu and she's like a lot of people with that religion. A lot like all animals are sacred to them.
hmm
So that's something I learned that was pretty cool, like interesting that I
Don't they
didn't know.
walk around freely or something in the country or something like that?
hmm Yep. So, and then just like like we said earlier, the best way to learn about somebody's culture, right, is to ask about it. Um, And so there's a lot of different cultural variations, and there's a lot of things that we have to take into consideration when we're caring for members of other cultures. I think probably one of the most interesting to me that has happened in my years as a nurse, direct eye contact, yeah, absolutely, is another potential one. Um, I had a resident, this was pre-COVID, so probably like 6 or 7 years ago. Um, the family had actually brought her into the facility. I work overnights. They had brought her into the facility for respite care. She was actively dying. And so the family was sitting vigil at her side. And I don't think that they were Muslim, but they were Middle Eastern, and I'm not sure what religion they followed, but I remember talking to her son, and as I had left the night before, and I tell you, this lady, she was a tough one. I left, her respirations were six. Okay, so she was only taking 6 breaths an hour or 6 breaths a minute. And so I was actually pretty sure that when I came in for my next shift, that she was not going to be with us anymore. But when I came in the next night, she was still there. Um, so actively, though, she was actively dying. So I asked the son because I was like, don't want to, um, don't want to violate any of their preferences, any of their religious requirements or anything like that. So I said, after she passes, is there anything special that we need to do regarding the body, right? Because like some religions, you don't provide more post-mortem care because that's actually a ceremonial thing that is done. Like I know with the Jewish population, once they pass, there's that is part of their ritual when they're getting the body ready for burial. So I knew it was something that I was not familiar with, so I asked. And he said, no, everything was fine. He said, just don't shave any hair, which I found very interesting because generally speaking, we're not in the habit of shaving people when, after they pass. The only thing that I could think of was that she did have some facial hair, as we get older, we get the little whiskers. She did have facial hair. Um, which I don't know if that's what he was referring to. But he was like, no, no shaving of any of her hair. And I was like, okay, yeah, that's not a problem. So I just made sure that my CNAs knew when they provided postmortem care not to shave her face of the whiskers and stuff. And I just thought that was an interesting, and I really wish that I had asked um what their religious beliefs were, what their religious affiliation was, just so I would have had that, in the back of my head, for future reference. But I just thought that was an interesting. Um, we had another one, this was years ago, back when I was at LPN practicing. She was it was an older Jewish lady who had passed away. And I had called her daughter to come in and just to let her know that her mom had passed. And her daughter and her granddaughter, the daughter and her daughter both came in. So her daughter and her granddaughter, they went in, they saw grandma or mom, and they came out to the nurse's station and she asked me for a pair of scissors. And I was curious, but I, handed her my bandage scissors because that's the only scissors that I had. She took her scissors and she cut her shirt. And then she took and cut her daughter's shirt as well. And so I always thought that that was interesting as well. And I'm assuming that's part of the mourning process. And the CEO of our company, he was Jewish. And so I asked him about it, and he said he didn't have any idea. He was, I don't practice my religion. I was like, okay, that's fine. So I never did find that one either, but there's just different things that you may come across, and it's just like we've been saying, right? The best way to find out about that is to always ask. Especially in situations where you're unsure and you never want to assume, because you don't want to violate any of those potential religious or cultural preferences that they may have. Um, and other parts of culture too, even here in the United States, we have such a diverse community. And of course, the area that you live in is going to determine how diverse that area is. So I'm going to use Virginia. Virginia, we had a lot of different cultures. Um, we had a large African population, a large Filipino population. Um, a large Black population. And I don't know, the Hispanic population was probably, I don't know, probably not as high as it is here in Texas. Um, and trying to think what else we had. Um, Trying to think. Now I can't remember. I guess I've been gone out of Virginia for too long. It's not even been a year yet. And so working with those different cultures, you kind of learn, right? So the cultures that you deal with most often, you'll get to know a lot about. Is it possible for you to know about every culture in the whole wide world? No, you can maybe know a little bit about a lot of things. My aunt, she's a nurse in New York, and where her hospital is located, she has a large Chinese population, right? So she got to learn a lot of those different, cultural beliefs and she works L&D. So it depends on where you live. Now down here in San Antonio, There is a very large Hispanic population here, right? So a lot of the patients that I work with are Hispanic. Um, and I, no, hence the last name. I do not speak Spanish, so it is a little bit of a roadblock. I adopted this last name from my husband. But yes, so, and that brings us to a whole new, all right, how do we work with clients that don't speak our language?
Interpreters.
Interpreters, absolutely. Um, and what if we broke that out and, we may have, we may work in an area, we may have, in a hospital or a clinic, right? You may have a few people that don't speak your language, that you can use, the interpreter lines for. But let's pull it out into the community. All right. So what about, when we look at providing care to the community as a
Duolingo. It's an app on your phone.
Duolingo, yeah. I actually had to pull that out not too long ago for one of my residents because he had had a stroke, and I know the man knows how to speak English because I've actually spoken to him in English before. But now, like, he reverted right back to Spanish, and so now we're having a very big communication barrier. So I did have to pull that out because I was like, I told him, I was like, I know you speak English because we've had conversations, but he's like refusing to speak English now. So that's a really great app. I like it. Um, because we don't have an interpretive service that we use at that facility. So Duolingo is one of the best ones that I've come across. Um, but yeah, so what about the community? What if you have work in a community that has a large population of non-English speaking, people, and we need to provide education and resources, when we look at our community efforts. How do we establish trust within a non-English speaking community?
Body language. Like
Okay.
not like, having a nice smile, not frowning, not looking confused, not having a threatening body language,
Okay.
like
So
standing
open
over
body
someone.
language. Okay. So anybody ever been to New York, into New York City? No.
Mm.
Um, well, a lot of areas, and I just use New York because that's, where I'm from originally, right? We have areas like we have Little Italy, we have Chinatown, the area that I grew up in that is with, my Polish side of the family, it's called Greenpoint. So it's a largely Polish community. And next to it, of course, we have Harlem and we have Spanish Harlem, right? So we have these little clusters of communities where
The
they're
Hasidic
predominant.
Jews.
I'm
I
sorry,
saw that. The Jews.
the Jewish population, right?
Mhm.
Yeah, Bensonhurst, yep. Um, so we have these pockets of communities, where the primary language within those communities is their native language, right? Spanish, Chinese, um, oh my gosh, and even some of the Polish, and they grew up speaking Polish. I never learned Polish either. We can talk about a hard language to learn. Um, but if you're gonna work within the community, every community has a leader, right? We think of leaders within the communities, right? We think of mayors and we think of governors and senators and those types of people. But within these communities, especially with immigrant communities or the non-speaking, they have trusted leaders, right? They have, whether it's a member of the church, whether it's a member of a political organization, they have trusted leaders that they follow, right? That kind of help them to assimilate into society within their wherever they're living. Um, so when we look at that, we find out who those community leaders are, right? So we go and we can, meet with the community leaders, and then work with those community leaders to develop a plan to meet the needs of the community. Those community members know the language, they know how to reach their members in that culturally appropriate manner. So that we can, provide information to them. There's also looking at within those communities, they have their own, a lot of them have their own little newspapers. So we can do, advertisements in their newspapers, we can make flyers, we can do radio announcements. And if we can build that trust with the community leader, that will help us to kind of get into the community to provide the needs that we need to address. Very people um and it's always about maintaining that open and objective attitude towards each person as well as their cultures. Again, we know that everybody within a culture is the same. They may not practice the same beliefs and the same customs. So that's why it's really important that we kind of ask them. One thing that we do have to look at too is something called cultural awareness. Now, the name kind of, or the title, or the words kind of are a little deceiving. But what is cultural awareness? It's
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 like
like
to be
being respectful or something.
it could be.
Or being
Um,
aware that their cultural beliefs aren't your cultural beliefs. Is it something like that?
so you're on the
Or
right track.
respecting it?
You're on the right track. It's our self-examination. So cultural awareness is looking at yourself first, okay? And it is a self-examination where you're identifying what your own biases and your own prejudices are. Um, and so, in order to provide culturally competent care, okay, you have to know yourself, right? And how, the things that you believe, whether they're true, whether they're, just a prejudice or a bias. Um, and so you have to do that self-assessment first. Because if, and then sometimes it's hard, when we look at, working with members of different cultures, and not really understanding those cultures, it could kind of make us feel like we're not providing appropriate care, that we're feeling, we may feel a little inadequate. But the first part of providing culturally competent care is to do that self-assessment. Cultural competence, okay, um, is providing that culturally appropriate care to our clients. And when we look at, how to develop cultural competence, we want to make sure that we're sensitive to the cultural implications every time that we meet with that client. We want to avoid stereotyping based on their race, based on their ethnicity. What is stereotyping?
Putting a group of people in a category where it's negative or even positive sometimes.
Judging.
Right. And we always think of stereotyping as, a negative thing, right? But there are positive stereotypes out there as well. But yes, so we want to avoid stereotyping, right? And that can just be, avoiding the fact that, we're kind of just clumping everybody together. And it could be, I don't know. I'm trying to think of a stereotype. like, um, I'm trying to think of one that's not going to be, like all,
They'd be like, sometimes I'll be hearing like all Jewish people got money.
no, that's a good one. That's a stereotype, right? And we know that's not true.
Hmm.
Um, like all Dallas Cowboy fans don't like the Buffalo Bills, okay? Right? It's, like just clumping people together into a group that, just because they're a Dallas Cowboy fan, right, doesn't mean that. So, we need to try to avoid that. And so we always ask questions. You can learn about different cultures. You can read about different cultures on your own. And like I said, I mean, that's a good way to kind of understand some of the cultures that you may come across in your areas. Are you ever going to really know everything? Probably not. But as you work in practice, you're going to get to know the cultures that you're going to work with the most. Again, never making, even somebody, who was it? Was it Winnie? You were talking about body language, right? So that's another one too, right? Don't make assumptions, you know, um, about those nonverbal cues, right? Some cultures don't maintain eye contact. In some cultures, you may not get to talk to the female. You have to talk to the male because they're going to make the decisions. Like we had a family, again, don't remember, been a long time. Um, But mom would always bring the kids in for their checkups, their immunizations, and all of that stuff. And no matter what it was, she could not make a decision. So if they had to get a shot, like a vaccine or something like that, she would have to call her husband, and I would have to talk to her husband. I would have to tell him, what the shot is, why they have to get it, like all of that stuff before he would give his permission to get the, whatever it was done. Um, so we have to, if they don't make eye contact, touch is another one. Be very careful with the use of touch. Some cultures are very touchy-feely, other cultures are not. Um, so again, you want to avoid that, being judgmental. Oh my gosh, they're not making eye contact with me, they're not telling me the truth, whatever it is. Um, And then another thing is, another term that we'll may hear too when we talk about culture is something called ethnocentrism. Has anybody heard the term ethnocentrism before? So ethnocentrism is the belief that one's own ethical or cultural group is the best, right? So, my Polish Catholic background, that was the best way to grow up. There's no better way than that. Okay. So that's what ethnocentrism is, right? It's just believing that your culture is the best. And we try to avoid that as well when we're working with patients. Um, we don't want to judge anybody based off of their culture, or their background, and just making sure that we are being very sensitive to their needs. Um, Another thing too with the use of interpreters. So interpreters are great, and that's the best way to work with, people of different cultures and different languages. And just as I don't know what the word is, this is more of like, I guess, a FYI kind of thing too, when we're working with those, having to use interpreters. Um, think about who you're interpreting for. Okay. So, if you have a Muslim man, let's say, doesn't speak English, do you want to have a female interpreter? Right. We'd prefer to have a male interpreter, right? Even with some others, we may also want to look at age as a potential, right? So if we have, a younger man, do do we want an older woman, or, try, I know in some cases we don't have the chance to use, or to select our interpreters, but we do need to be mindful about using interpreters as well. Why do we not use family members as interpreters?
But some of them don't understand the medical needs.
They may not understand the medical terms, they may not understand the medical needs. What else?
They can
They
lie.
You just threw that out there like it was yes, and it's true. They can lie. And no, we don't maybe want to use the word lie, but they may
They
not give us the full truth, right?
yes. They might not even give them their real diagnosis, like when they're telling them what it is. Like,
Absolutely, right? So we do need to be careful with that. And that brings me into one more story. Like I have lots of stories, but we had a resident, this was again a long time ago, back when I first started nursing, I was still an LPN. And we we had I don't know if she was Chinese or Japanese. I just know that she was I just know that she was Asian, but she did not speak English. And so, um, come to find out as we were in the process of admitting her and getting her set up with, services and stuff, um, it turned out that she had cancer. She literally, her cancer was at a stage 4. She was terminal. Um, she was not receiving treatment, so she wasn't getting chemo or radiation or anything like that. And we found out from the son, because the son did speak English, that the mom didn't know she had cancer, and they had decided, I don't know if the son decided this on his own or if it was like a decision amongst the children, whoever, that they didn't want her to know that she had cancer. So they made it a point to tell us, because if it did, like it said, we found it in the charts, that if we did find out that we were not to tell her, which I will tell you, when you talk about ethics and you talk about
But
moral,
why? Why didn't they want her to know? It'll probably break her heart.
right? And I don't know why, honestly, don't know why they didn't want her to know. Um, I know that they did not want her to go through the cancer treatment, the radiation and the chemo, because they felt that she could live a better life without the treatment, and kind of just live her last days, um,
but that's not her right to know.
see, and yeah. So that brings up some really good, that's where I'm saying ethics and morals, right, kind of come into play. Um, as healthcare providers, absolutely, we feel like she had the right to know, right? Somewhere along the line, and I don't know when or how, but her son had become her power of attorney. And because he had become her power of attorney to make all decisions for her, we could not go against his wishes in that situation and tell her that she had cancer. So yeah, it was a
That kind
very
of
uncomfortable situation.
that kind of happened to my grandma on my dad's side. Well, my grandma, she had lymphatic cancer and stuff like that. But my aunt knew for like years of like a year that my grandma had cancer. My family's from Liberia, so like what she was doing was home remedies to cure the lymph nodes and stuff. So when it came to America and it got worse, um, nobody knew that my grandma had cancer until she was living on her dying bed, and then my aunt was the power of attorney. So
Oh,
like they
wow.
was arguing like, they're fighting over land. That's the reason why she didn't want to say nothing because she knew it was a whole thing, but she didn't. Nobody knew she had cancer until like she had a week left to live.
Oh my goodness. Oh my goodness. Yeah. And yeah, that's obviously a different situation, right? They were trying to, whatever the land issues and things like that, right? I don't know why he had decided not to tell her. And yeah, and like I said, it is right. It is her right to know and understand what, and even make the decision, right? Maybe, if she had been offered the information, maybe maybe she wanted chemo, maybe she wanted radiation there, whatever the treatment was, But they had taken that away from her. So she didn't have that opportunity. And oddly enough, she was with us because she had had, I want to say hip surgery. I don't, it wasn't her knee. I think it was her hip. And so she had just come to us for rehab, right, to get her back on her feet, so that she could, just be self-functioning again at home. So it's just interesting. But yeah, we were not allowed to say anything to her about her diagnosis. And way back then, I feel like I'm really old. We didn't even have an interpreter. We didn't even have computer charting yet. That's how long ago this was. Um, so access to like interpreters and stuff like that, we had to rely on the family. We didn't have much of a choice in that situation. So yeah, it was just a very unique situation to be in. I hope never to have to be in that situation again. It is something though that you may come across depending on the culture, and how what the family structure is. And so just something to be aware of. It is not, the easiest situation to be in because we were all, of course we all talked, she couldn't really understand us. But we're like, this isn't fair, right? She has the right to know. But in that case, we didn't have really any leeway to provide that information to her. Um, but yeah, so it's just interesting, some of the things that you may come across. And like I said, it depends on, where you live, what, the population of your area is, how diverse, how unique that population is. Um, in some areas you may not even have, a whole lot of different cultures. Just kind of, it's just interesting how, one area to the next, and the diversity of those areas. So, but all right, does anybody have any questions on, so any questions? But so I can't remember when our last exam was. Whenever exam 2 was at week 7, 6. Oh my gosh, that's bad. I don't even remember when exam 2 was. Exam 2 is week 7. So exam is going to cover week 7, 8, and 9. So week 7, let's see. Whoops, that's the wrong one. So week 7 was infectious disease prevention, HIV, tuberculosis, and sexually transmitted infections, bioterrorism, as well as disaster planning. Then last week, for week 8, we talked about chronic diseases. So we talked about post-op patients, cirrhosis, diabetes, peripheral artery disease, chronic venous insufficiency, hypertension. And then this week was our cultural competence, and our violence. So those will be the topics for the exam next week. Um, so again, any questions before we sign off? Any questions about any of your assignments that are due? So again, you still have your HESI prep assignment, you have your vulnerable populations project, and then you have your week 9 Saunders questions, your week 11 Saunders questions. And if you want me to, I will open up your week 11 Saunders questions next week. So if you want to get those turned in a little bit earlier, then you'll have that option. So I will do that now. So I will have it open, from the 7th. This way you have that, a lot of people are going to be worried about HESI week because, I know that community is not your only HESI you have that week. So, but any questions whatsoever?
Do you do a HESI review?
Yes. The HESI review is, oops, wrong. Go over that. Come on, Fortis, work with me. Come on, Canvas. There we go. All right, so this Sunday at 7 p.m. is our exam 3 review. The 14th at 7 p.m. is the HESI review. Okay, so next week we have the exam, so there's no class after the exam. You take the exam and you go. Week 11 is HESI, and then week 12, again, remember for week 12, we meet on the 23rd at 1 p.m. to do our check-in for your week 12 attendance. Okay? All right, guys. If you don't have any questions, you are free to go. Have an awesome week, and I will see you next week. Or I'll see you Sunday. I'll see you Sunday.